Welcome to the AUANews Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Welcome to the AUANews Inside Tract. I'm Dr. Andrew Harris. I am chair of the American Urological Association's Quality Improvement and Patient Safety Committee.
And I'm Dr. Amanda North, and I am a former chair of the AUA Data Committee. And now I am on the brand new AUA New Technology and AI Committee.
So today we're going to be taking a look at the AUA's new Quality Improvement Issue Brief on physician burnout and joy in work, and why burnout is not just a workforce problem, it's more of a quality patient safety issue. We know burnout increases medical errors, adverse safety events, affects patients' access to timely care. And that's why this brief really shifts the focus toward what we call joy in work and system level solutions, not just individual resilience. So we're excited to get into that and discuss this today.
Well, Andrew, or Dr. Harris, sorry, you are an expert on quality improvement, and you're also an expert on burnout. And I think most people think of burnout as being almost a personal issue, like there's something wrong with me because I'm having burnout. But here in this quality improvement brief, we talk about how burnout is not just a personal issue or isn't primarily a personal issue at all, but actually a QI issue. Tell me about that.
Yeah, I appreciate those thoughts. And I think as we have gained a better understanding of burnout and a lot of the work that you did in your time with AUA Census, which we were all benefit from that work, we started to learn about this constellation of symptoms and further what are the associated issues that can lead to downstream ramifications that affects our patients. And so really have had the opportunity to learn quite a bit about how it shifts from the individual focus to everything that individual is now involved in. And for us as physicians, that is patient care. And so when some of the ramifications of burnout start to affect our patients, that leads to issues with quality and patient safety. And so if we can talk a little bit about those issues, wonderful study that took a look at the associated symptoms of burnout. And, we talk a lot about depressed mood and loss of interest or pleasure. However, when you get into a little bit deeper what other symptoms, you might see insomnia. It's really hard to come to work and be a, functionally phenomenal physician when you're just not getting enough sleep. Psychomotor agitation, that is challenging for us in our job if we have some of that. Loss of energy or fatigue, it makes it hard for us to think about the patients that are in front of us to give them the care that they need. We might see diminished ability to think or concentrate, or even difficulty making decisions. And in our line of work, that leads to difficulty with good outcomes. Memory impairment, right? That's associated with burnout, and that is integral to our success as physicians and those patients that we treat. And we also might see somatic complaints, and it's hard to work when we're in pain, right? And if we are in the operating room and we have to be able to deliver care and we're in pain, that is not good for our patients. And we also see increased irritability, and we know there are definitely associations with irritability in the outcomes for patients. So I think when we talk about the symptoms that can be associated or characteristic of burnout, a lot of them have direct impacts on how we deliver patient care. And when you take a look at the volume of our specialty that does experience some of the symptoms of burnout, well, now that makes a fairly easy transition into, okay, this is not good for our workforce population. It is also not good for our patients because of all of the issues I just mentioned. And when you take a look more in depth, you start to see the quality of care suffer. You see a decrease in the number of healthcare workers. You see an increase in malpractice cases. You see increase in physician turnover. You see increases in absenteeism or cutting work shifts. You see an increase in physicians working less hours because of the burnout, so decreased productivity. And that leads to an overall decrease of expertise in the field, which all of that is directly related to our patients. And so let's get into a few numbers and data to support what we're talking about. All right, physicians with burnout are 2.2 times more likely to report medical errors. They are double the risk of patient safety events. 7 to 10% of serious medical mistakes involve physicians who are experiencing burnout. We see if you have a 10% increase in employee burnout, that can be associated with 1, urinary tract infections, and 2, surgical site infections per 1,000 patients. I mean, that is a significant number. that is not good for our patients. It can cost up to 4.6 billion annually in the healthcare system. And we've also seen a 1 point drop in professional satisfaction can lead to a 30 to 50% higher chance a physician will reduce their work hours. So some pretty decent data showing significant issues in quality of care, safety of care, access to care in physicians who are experiencing burnout. So that's one of the reasons why we felt very strongly of moving this conversation forward a little bit of not just how do we look at physicians with burnout, how is it affecting our patients? And that's allowing us to get some more push behind how do we have a better discussion about mitigating burnout.
Yeah, I was thinking also when you talked about the interactions with the patient, we know that one of the components of burnout is this idea of depersonalization or losing connection with the patient as an individual and more objectifying patients. And we know that that patient physician relationship is so critical towards trust, towards outcomes, but also towards malpractice suits, right? If the patient feels connected to their doctor, the incidence of malpractice goes down. And when the physician no longer feels this connection to their patients because of burnout, then you're going to have poorer outcomes, like you stated, but also a huge increase in malpractice suits, which is problematic for our healthcare system.
Yeah, I appreciate those thoughts. And it is likely that those physicians that end up going through those malpractice suits are going to have less burnout, right? That's probably going to contribute and compound the problem more. And so, I appreciate those thoughts. And so when we start talking about burnout, how do you think you're shifting this narrative also from burnout to really fostering joy in work? What are your thoughts on how that helps address burnout in this discussion?
Well, I'm going to go back a little bit and talk about how many hospital systems choose to address burnout. Let's have Pizza Friday for our staff. That's going to make burnout go away, right? Or let's offer a class in mindfulness meditation to address physician burnout. And I am a huge fan of mindfulness meditation. I think we should all be doing it because it's good for us. But that has nothing to do with my burnout at work. My burnout at work is caused by inefficient work systems, understaffing, too many patients to be seen and not enough time, the perpetual push to generate more RVUs for less money. All of that drives burnout. And so pizza parties and mindfulness meditation and doing yoga and exercise, well, look, I love pizza, don't get me wrong, but that doesn't fix the underlying problem. So when we talk about restoring joy in work, we're talking about taking a systems approach to improving our everyday work lives by making things run the way that they should, right? There's nothing more frustrating than working in an operating room where the turnover time takes longer than your cases. Well, one way to restore joy in work is to take a team's approach to looking at what factors are creating long turnover times in the operating room. Or, and I know you've done some of this work, looking at how do we make sure that the equipment we need in the operating room is readily accessible when we need it. So we're not stopping for 15 minutes in the middle of surgery while a nurse goes and finds the equipment we need from the center core of the operating room, right? Let's look at what is causing backups in our clinic. Are we not scheduling effectively? Are we not checking the patients in effectively at the front desk? Are we having trouble rooming our patients because it's taking too long to get vital signs? Where can we streamline our clinic operations? Is there a way to do a telehealth visit while they're rooming the first patient of the day so we can get some of that done without getting home late and missing dinner with our families? How can we use AI to make sure that our clinic notes are done at the end of the day so we're no longer spending date night with Epic when we should be spending date night with our spouses and families, right? So these are why focusing on joy in work rather than the resiliency of individual physicians is a more effective strategy to addressing the real root causes of burnout. Listen, There's not a urologist on this planet who isn't resilient. You can't go through all those years of medical school and residency training and a very difficult surgical residency and not develop resiliency. So focusing on our resiliency is incorrect. That's blaming the victim almost, but focusing on what's going on in our work lives and how can we make that better, that's a much more effective strategy to addressing burnout.
I appreciate those thoughts. You want to go down two different lines of thinking. The first is I appreciate your thoughts on what doesn't work, and I think that resonates with many of us because especially when we were going through learning more about burnout and we were seeing it becoming more of an issue. A lot of it was let's go do an exercise class together, or let's learn how to do yoga. And it's not that all of those things aren't great, but they may not be treating the root cause of the burnout. And I do think there was some backlash a little bit. And I heard this from other physicians, like, stop telling me I'm the problem. Like, I am not the problem. You are hurting me by all of these extra things you're making me do, or you're putting me on an RVU system, which I have no control over how efficient the system runs. But I'm the one left holding the bag at the end of the day. Excuse me. I've had multiple physicians tell me that. And they're like, Andrew, it's just so frustrating because I can't do the amount of exercise I need to do to mitigate how I'm feeling when these things happen in the hospital. I feel like there's no helping, like such a leadership disconnect. So for any leaders who are listening, your opportunity is to talk to your people who you serve and have a discussion about what is working and what is not, which brings me to my next line of thinking I wanted to bring up is really finding those pebbles in the shoe, because they may not be the same everywhere, right? You brought up several ideas and pain points for physicians, but they may not be the same everywhere. It may be clinic for some people. It might be, I can't get through my clinic notes and I need some AI listening tool. It may be that, you have me on this RVU target that I'm happy to do, but my turnovers are way too long and I'm missing dinner with my family and my operative time is half of what my actual OR time is. And that's really frustrating for me. And I think a lot of times leaders have a better opportunity to engage with the people they serve to talk about, okay, what is our situation? Here's what the literature shows. It can be all of it, but what is ours and how can we help? I really appreciate your team approach. I feel that sometimes we have been disconnected for that. Surgery is the biggest team sport, in healthcare, right? Like we need everybody in surgery to be successful. And sometimes I feel like we've disassociated our teams a little bit based on some of the system structure that we've set. So I really appreciate your thoughts about how do we get back to being a team and figure out these things together, because everybody is happier when it runs better, right? And I think most physicians, we went into medical school and urology because we want to help people. And all of the things that pull us away from just being able to show up and help people are frustrating. And it makes it hard.
Well, and I think we're trained to be good surgeons and good clinicians, but we're not trained to necessarily be team leaders. And, I think a lot of what we talk about in this QI brief is how do you lead a team to, make change that is effective for everyone? And part of it is learning how to listen to everyone on that team. And if we're talking about clinic, it means talking to the front desk people. What isn't working when we're trying to register patients at the front desk? What's the problem there? Or talking to the nursing staff, your MAs or your LPNs who may be rooming your patients. What can we do to streamline rooming patients and patient readiness for me to get into the rooms faster? Or thinking about how can I get through my notes more efficiently? We've started using AI scribes in our clinic, and even learning how to use that has been, a little bit of a learning curve. But how can we make sure that at the end of the day, all of our clinic work is done and ready? How do we streamline our inboxes, right? I mean, I think my chart messages and inbox stuff can be a huge pain point. Can we have an APP or an RN, take a first look at our inboxes to take some of that burden off of us? But learning how to manage the team and that team approach isn't something that we're really taught in residency. And I think that it's something that, I wonder if our administrations would do better teaching us how to help make a team more efficient rather than giving us classes in mindfulness meditation.
Yeah, I love those thoughts. I appreciate what you're particularly saying about the opportunity to be better team leaders. And I think in the operative setting, when we're operating, we are phenomenal. Like we're taught, if somebody starts bleeding, we know what to do. We know how to instruct everybody. We know how to captain and lead that ship, so to speak. When we get out of that arena, it's a real challenge for most surgeons. And I think a lot of it, and all physicians, is because we're not taught to think in this way, because we make decisions so quick. And one of the best anecdotes or kind of stories I have for this is I was doing a cystectomy as a chief resident with a world-renowned, bladder cancer surgeon and sick patient. And he started with me at the beginning of the case. This guy's got to get off the table. And I couldn't keep up with him. And I was a chief. I was getting ready to graduate. I thought I was doing okay. And I couldn't keep up with him. And at the end of the case, I was like, wow, that was really impressive. We did that in under 3 hours. And he looked at me, he said 3 hours and 30 years. Because that's how long he'd been doing it. And we spend so much time in training, and we are algorithmic, and we are problem solution, but it's taken us a long time to get there. If we wear that same hat into trying to solve some of these problems, it can be real challenging because we haven't done the same, 15 or 20 years to get that knowledge base of how to solve system problems, but yet we want to make decisions the same way we make them as from our surgeon hat. And that can make it really, really challenging. And so I agree with you 100% about teaching people how to do this. And the AUA has also put out a quality improvement project guide that can help walk people through at least how to lead some of this work, which might be helpful for some that are interested.
Yeah, and the other thing I've been thinking about in association with this quality improvement brief is figuring out what aspects of our jobs actually bring us joy. Taking a little time to think about what do we actually love. And it's funny because I was having a conversation with my husband about the different places that we travel for my job, and how much I love going to the advocacy summit. I love going to Capitol Hill and talking to the congressional offices. It brings me joy. You feel like you're making change at a large scale level. And for me, that is fun and exciting and something I look forward to every year. And it may not be the same for everyone else. I had the opportunity to go to the SWU meeting in Nashville. And what a battery filler that one is, right? I mean, we had an amazing keynote speaker. I'm still thinking about what she had to say at the meeting. I had the opportunity to ask her some questions, connect with these amazing women. That really recharged my battery and helped me get through a rather difficult winter in New York, because I felt really energized by those connections. A great day in the operating room can recharge your batteries, right? Just as much as a bad day in the operating room can make you really question all your life's choices. But I think spending time thinking about what types of patients do I really enjoy seeing? How can I try to see more of that type of patient? What kind of marketing or outreach would I have to do? And what types of, career related activities bring me joy so that I feel recharged and ready to take on those challenging days. And I'm wondering what your thoughts about those types of things are.
Yeah, well, I have some thoughts, but it's a wonderful segue into where I think of our last topic for this podcast leads. And that's like, what are some of the real world interventions? And I really wanted to comment on a few things that you said. And the first was just how individualized your kind of battery fillers may be, right? And they may not be the same for everybody. So really, how do we take a look at work-life integration on an individual level for leaders to allow this burnout mitigation or joy in work to be successful, and stop putting everybody in one size fits all, right? Stop putting everybody's, your clinic has to be this time and your OR has to be this time and you got to function. We're not the same. We like different things. We want to function different. How do we work the system to enable us to be more individualized in how we would like to function? So that was one thing. If you could comment a little bit more on the second one, then how you mentioned the advocacy summit, how can we move away from the individual part that is important, but also how can the system at a state or a federal level start to support physicians being able to show up and do their job?
Well, and I love your point about, work-life integration. One thing that pops to mind is, our institutions, and more of us are now employees, right, rather than practice owners. And so we're partly at the whim of our institutions, but I do wish hospital leaders and department leaders would allow a little more flexibility in our schedules. For me, I've always been a morning person, so I like to get to work, get my work done, and try to get home in time to have dinner with my family. That's always been my thing. But I know I work with someone whose great joy is taking his kids to school in the morning. And so an 8 o'clock clinic start time isn't great for him because it doesn't allow him that hour of joy with his children in the morning. A 9 o'clock start time would be much better for him. And he doesn't mind working a little bit later to get that special morning time, which is more valuable to him than it was, to me. My kids are big now, of course, but when my kids were little, I didn't value the morning time as much as I did the after school time. And so allowing a little bit more flexibility in how we do our schedules, to allow people that work-life integration, I think is one thing that we should think about. Um, and, it's hard. It's hard for hospitals to allow that because our schedules are dependent on a whole team, as we talked about before. But I do think it's one thing that I'd like to see. The other thing I would say is that advocacy has a lot of different levels. The Advocacy Summit is big A advocacy. We're going down to Washington, D.C. We're meeting with congressional offices. Or you could do state advocacy where you're going to your state capital and talking to people there. But advocacy can also start at a much smaller level. It can be at a departmental level. It can be at a hospital level, right? And so I think giving people the tools they need to advocate for what they need to be successful doctors and be fulfilled doctors and have that joy in work, is really important. And it's not just big A advocacy, it's also little a advocacy. And so hopefully our QI brief helps give people some thoughts as to how they might start doing that.
Yeah, I appreciate those thoughts. I know one of the big topics at the Advocacy Summit this year was prior auth, and I'm sure everybody listening just got a twinge somewhere because that is challenging for all of us. And I think there are ways to make change and to get involved, whether that be in your city level, state level, federal level, to help work towards trying to make things better. Because if we don't speak up as a group, people will assume we don't have a problem. Right. And so that is another option of how we can foster joy in work, because nobody enjoys things like prior auth. But unless people fill out the census, plug for the census, and let their voices be heard, then it's hard for everybody to understand where we need to go to try to make people better from a national or even state level. So I appreciate those thoughts. Any last key takeaways while we're looking to improve joy in work at the local environment?
Yeah, I think the worst thing that can happen to us as doctors is that we give up and feel like we no longer have any voice at all. And so the first thing I would say is we have choices and we have the ability to implement changes. It's not always easy, and change sometimes takes time. But I think that there are ways to restore joy in work. And hopefully we've given some insights here, but there's also the QI brief, which is published on the AUA website. So please take a look at it. And we're always happy to collaborate with people to further look into these options. So please feel free to reach out. And, medicine is hard right now. I think for many of us, medicine is hard right now, but that doesn't mean that it can't get better. And so I want to give a little bit of hope to people that are struggling, that it is possible to make things better. And I have great faith in our ability to do that as physicians. And Dr. Harris, what are your final thoughts?
Yeah, I appreciate the question. Surgeons are leaders by nature, whether you want to be or not. You went into a surgery field, you're a leader. That's just the way it is. If you see a problem, take the opportunity to change the narrative from a problem to an opportunity and put a team together. People will follow you. And use the AUA project guide if you don't know how to do this kind of work. People are around. I'm always happy to help. And find what bothers people, put a team together, and work to try to make it better. You will find joy and you will find engagement for people around you if it's a problem that resounds with others. And people will be excited to try to make things better. They just need a leader. So I would encourage people, you're a leader already. If people see us as leaders by what we do, put a team together, find a problem, and try to fix it. and whatever you're going to do is probably going to be better than whatever you have now. All right. So take a chance
Amen.
and take that hunt and try to do something.
Yeah, I love that. I love that. Well, it's been really great talking to you about a topic that I know we both care about deeply, and I'm sure there's more to come on this. So I don't know that burnout's going away completely anytime soon, so there's always more work to be done.
Yeah, and I appreciate the opportunity. And to our listeners, thank you all for listening to the AUANews Inside Tract.
This has been an AUANews Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.